Good morning. So I'm just going to start with two cases, not nearly as exciting as the vascular trauma, but these are a much higher frequency event for us. So the first is a 6-year-old male. He's a restrained backseat passenger in a motor vehicle collision, Carver's tree, no loss of consciousness, hemodynamically stable. And in our institution, we have a tier trauma activation system like most, and this was a level B. His GCS was 15, heart rate 131, normal blood pressure on the primary survey, and on secondary survey he had some cervical tenderness to palpation, and he had some significant abdominal pain with the seatbelt contusion, but no obvious peritoneal signs. Hopefully you can see the seatbelt mark just above the umbilicus there. Same vehicle, patient's sister, 11-year-old female, restrained backseat passenger. Again, car versus tree, found slumped under the driver's seat and did have some loss of consciousness. Also a level B. Her blood pressure came up quickly with some fluid. Heart rate was 118. Also some cervical tenderness to palpation and some fractured incisors, but a pretty normal abdominal exam. So the considerations, the thing, and we talked about this yesterday, most of you practice at an adult center. And in our adult trauma center for the level B activations, pan CT has become extremely common. And at the pediatric centers, we still practice selective CT. So just a show of hands, how many of you for the level B or second tier activations commonly get screening labs, CBCs, LFTs? Most of you guys get those. All right, what about plain films? Does anybody still do a chest x-ray in the trauma bay on a stable patient? Pelvic plain film, does anybody still get a pelvis x-ray? Not too many. All right, what about fast? Raise your hand if the trauma surgeons do fast on the level B or the second tier activation. All right, great. So, in these two patients, the first patient, the brother, had a hematocrit of 37. His AST was normal, and then his chest x-ray was normal. The sister, only abnormal lab was her AST was 222, and on her chest x-ray, some pulmonary contusions. So, who would have ordered a CT scan on the brother with a seatbelt contusion? Raise your hand if you would get a CT. Would anybody go straight to the OR with the seatbelt contusion? All right. What about the sister? Same vehicle, but normal abdominal exam. Does she need a CT? Raise your hand if you would get a CT. All right. So, the questions I'm always asked is, just as I said, who needs a CT, and is there anything that can guide that for the stable trauma patient? And that really been the focus of my work. So the brother, this is his CT. It's a little bit hard to see, but there's some fluid in the lesser sac behind the stomach, and there was concern of a perforation or a hollow viscous injury, which we do see not uncommonly with the patients with the seatbelt contusion. And then the sister had a normal abdominal CT. So I'll just pause and say what we did with the patient. One of the things I think that has evolved in trauma management of these patients that are stable with hollow viscous injury is how you manage them operatively. And on the pediatric side, and I think some of the adult surgeons have adopted this as well, we commonly do laparoscopy for these patients. So this boy underwent a laparoscopy. We explored the entire abdomen. He had a jejunal perforation, and we just lifted the small bowel out through the trocar site, repaired it primarily, dropped it back in, and he did very well and went home a few days afterwards. So as I said, today I get to present some of my research, and I have put together a group of 14 level 1 trauma centers to really focus on this concept of who needs a CT. And you might wonder, well, why do we care? CTs, everyone gets them, they're widespread. But in kids, there's a pretty low incidence of injury. We do worry about cost. I know in the US we spend $3 trillion a year on healthcare, so you may be thinking, what's one more CT? But when you add this up over a population and many trauma patients, the cost does add up. And then in kids, of course, we worry about radiation. So just a little background, several studies have suggested that you can identify a low-risk population of patients that may not need a CT. And what we are up against as pediatric providers is that there is adult data out there that would suggest that pan-CTing these patients is more cost-effective. You miss fewer injuries. And so that's really the challenge, is that 90% of kids initially present to an adult center, and there are a lot of CTs that are done. Prior to my work, the PCARN group had focused on this, but they only really looked as an outcome variable patients that required intervention, which they defined as transfusion, urgent surgery or angiography. And they only looked at history and physical exams. So they didn't really look at labs and plain films. So the purpose of our study was to see, could we identify all injuries? The grade 3 liver laceration is important to the trauma surgeon, just as the patient with perforated jejunum, as I presented. And we looked at this for a year in 14 centers. We collected a lot of data. If patients had a previous CT, they were excluded. If they had an isolated mechanism, like they were punched in the face or a car ran over their foot, those weren't the type of patients. These were patients that sustained blunt trauma. And again, we looked at all injuries. And in a year, we collected data on almost 2,200 patients. You can see the type of mechanism that we had. Most of them were motor vehicle collisions or pedestrians or bicyclists that were struck by automobiles, ATV accidents. So pretty significant mechanisms of injury. 12% of the patients had an injury of any intra-abdominal structure, and 3% required an intervention. And I think the most interesting thing is 45% of the patients were scanned, which you may think, well, I'm used to seeing everyone scanned, but in the pediatric centers, that's not the case. But I think the variability is really what speaks to the heart of the problem. When you looked at 14 pediatric trauma centers, the rate of CT ranged from 4% to 96%. And that usually tells you, as a researcher or as a clinician, maybe there's something that we could do a little bit different. And I will say that 75% of the patients were admitted anyway. So that's what I call a captive audience. Those are the patients that, if you don't scan them, you can come back and look at them again and repeat their abdominal exam. So what we came up with, and we like to keep things simple, was a 5-variable rule. This was the order of the variables in terms of how important they were, what was the odds ratio of an injury. And the 5 variables were AST greater than 200, an abnormal physical exam like that seatbelt contusion, an abnormal chest x-ray, the patient complaining of abdominal pain, or abnormal enzymes. And what we found is that 34% of all patients that come in had a 0% risk of an injury requiring an intervention and a less than 1% risk of any injury. So that would suggest that there are definitely patients out there that don't need a CT. And the rule essentially had a 99.4% negative predictive value. That means if all 5 variables were negative, there's a 99.4% chance that you don't have an injury and a 100% chance that there's no injury that requires intervention. Looking at it, and the contrary is, what's the chance you have an injury if you have a positive variable? And as you might expect, as you go from 1 positive variable up to 4 or more, the risk of injury goes from 4.5% to 63%. And the risk of injury requiring intervention also increases. So that's something that you like to see when you're looking at variables and what's the risk of injury. I like to order the thing in the order that we find out the information. So typically, the first thing is the history, so do they complain of pain? The second is the physical exam. And in most of the pediatric centers, we still get chest x-rays and labs. Again, I get asked a lot, well, it takes 30 minutes or an hour to get labs, and I can't wait that long. It's too long. But most of these patients are stable, and even if you don't get labs back yet, you can still identify a low-risk population of patients that are very low risk for having any injury, and so it's definitely safe to wait. So what do we miss? What are the 0.6% of the patients? They're mostly grade 1 and 2 solid organ injuries. And all of these patients have additional injuries: femur fractures, pelvic fractures, pulmonary contusions, head injuries. These aren't patients you're sending home anyway. So most of those patients are ones that you're going to scan for other reasons. What if you don't look at labs and the chest x-ray? Well, the PCARN rule actually missed a lot of patients with solid organ injuries, and so we do think it's important to get labs and x-ray. And then what about going to the operating room? It may or may not surprise you that every single patient in the study that required an intervention got a CT scan first. So in the pediatric trauma population, it's pretty rare that you have a patient come in that needs to roll straight back to the OR. So we usually know what we have, and there's usually two or 4 hours in there where you're completing the workup. So in conclusion of this initial work is we felt like we did have a prediction rule that was pretty valuable. And again, most patients were hemodynamically stable, and we could pretty successfully predict who didn't need a CT. So of course, all the naysayers said, well, of course you found that. This is your own population of patients. You need to validate that in another data set. And so we were fortunate. The PCARN group had a data set with 12,000 patients. And so the next phase of the study was to take our 5-variable rule, apply it to their 12,000 patients. And just in the interest of time, I'll kind of scan through here, but the patients were very similar in terms of their frequency of injury or injury with intervention. Actually, in the original data set, they were a little bit sicker, a little bit more likely to be admitted or admitted to the ICU. The PCARN group definitely got more CTs than we did, but it probably wouldn't surprise you that our rule in a different data set had almost identical negative predictive value for injury and injury requiring intervention. And so what we found was that about 47% of the patients are low risk. So we're talking about a whole lot of CT scans. If you look at that across the entire United States, it could probably be a bit avoided in pediatric patients. I also get asked a lot by the smaller trauma centers, well, could we use this rule to decide who needs to be transferred? And it's a pretty valuable rule because I think a lot of times the referring level 3s and non-trauma centers feel compelled to get a CT scan prior to calling. And really, if you have labs and x-ray, you can pretty accurately predict who's unlikely to need to be transported because they're really unlikely to have an injury. So again, PCARN data set, almost the same thing. The few injuries that were missed were those that had solid organ injuries. A couple other things I get asked a lot is, well, what about the patient that's pre-verbal? You know, I don't like examining kids. I don't know how to get a good history and physical exam on a 15-month-old. Well, when we looked at this in the pre-verbal population, the rule still had a negative predictive value of 100%. Likewise, a lot of providers are uncomfortable skipping CT in patients that have a low GCS. And although the rule does not do quite as well in GCS 9 to 13 or 3 to 8, it still does pretty well. I'm not telling you don't get a CT scan on the patient with a bad TBI that's a little unstable. I don't think anybody's going to really take the rule that far, but it just goes to show you that the rule's pretty good, even if you can't get a good history. And then back to the seatbelt contusion on that first kid. What's the chance with a seatbelt contusion that you have an intra-abdominal injury? And in our population, it was 23%. So those are definitely patients that I would scan, but not necessarily take straight to the operating room, just based on the contusion alone. So looking at this in a second data set, the study performed pretty well. And this is what we send out to centers that ask, how do we do it? And currently we're looking at validating this in adult trauma centers. If it works in patients up to age 16 or 18 years, I'm pretty sure it's going to work in patients that are 25 or 35. I'm not sure about geriatric patients. They have a lot of medical issues. Sometimes they're on blood thinners, so maybe that's not the right population. But the next step of this is going to be rolling it out to older patients. I'm always asked by the pediatric surgeons to give the caveat that if you just have one variable positive, you don't have to CT scan, and that's why there's a little asterisk there for complaint of abdominal pain. Sometimes those are patients that are getting admitted anyway, and if their only concern is that they're scared and they're saying their belly hurts, but the rest of the workup is negative, you may be able to just admit them and observe them overnight. And as I mentioned yesterday, the other data I'm looking at is grade 1 and 2 solid organ injuries. I get asked a lot, well, what if I miss a grade 2 spleen? And the short version is, well, we typically tell those patients to avoid strenuous activity, as I mentioned yesterday, but the reality is they probably aren't going to need intervention anyway. I know I'm a little bit short on time, but I also get asked a lot about FAST. So for a variety of reasons, FAST is just not as sensitive in kids as it is in adults. When we looked at our data population, the sensitivity was somewhere around 30%. The specificity was less than 90%. When I looked at patients that had a FAST and also had an injury, the FAST was negative in most of the patients with a solid organ injury. So 33 of 42 patients with a liver lac had a negative FAST. 17 out of 30 with a spleen lac had a negative FAST. So you cannot use FAST in kids and say, well, the FAST is negative, they don't have an injury, because it's just not sensitive enough. FAST was really designed to look at patients that were hemodynamically unstable and decide, do they need to go to the OR? It was not designed to decide who you can avoid a CT scan in. And in kids, we often see that they don't have a lot of blood in the abdomen or free fluid, and that's really what the FAST is looking at. Again, looking at the 14 centers, we were center number 1, so we fasted almost everyone, and we only CT'd 20-some%. But there's really no correlation between how often you fast and how often you CT. What we think is that whoever's on that day, whether they like fast or not, they do it, and whether they like to scan or not, they do it, and they don't really use these prediction models to decide. So the final thing I'm going to bring up is, well, what if there's another way? Dr. Mooney, who's one of my colleagues at Boston Children's, is thinking, well, if the dolphins can do this, maybe we can use ultrasound in another way for the kids. And so I think the next thing that we're going to see, both in adult and pediatric trauma, is the concept of, some people call this a slow or a delayed ultrasound. But what's being studied now and has been looked at in Europe is there a way we can make the ultrasound more sensitive? And there's these bubbles that can be injected. The trade name is Optizon, but there are these little bubbles that you can inject while you're ultrasounding, and they're actually super good at helping look at the parenchymal injuries. As I said, really on ultrasound, we're mostly looking for blood, but in Europe, they've been able to look at this, and in a limited number of patients, the ultrasound with the contrast bubbles is very specific. The studies have gotten held up a little because of a worry about a cardiopulmonary reaction, but in follow-up, it doesn't seem that there have actually been many real reactions, and in adult patients, it's extremely rare to have reaction to the contrast agent. So I think we're going to start seeing a lot more studies looking at this. And right now, all of these organizations are seeking to end the black box warning on the Optizon. So this may be the next thing in trauma, is to start thinking about, can we use ultrasound, but to do this contrast agent as an alternative to doing CT with IV contrast. And in Boston, what they're doing right now is a pilot study looking at this. They've looked at 18 patients, and they're comparing conventional ultrasound to the ultrasound with the IV contrast agents, and they're finding pretty good sensitivity and specificity with the ultrasound. So hopefully that's going to be the next thing that you see. I don't know if there's any way to play the videos. Let's see, can y'all push play for me? So you may be able to see, this is an example of the standard ultrasound And then if you look, you can see in black up here the parenchymal injury. And this is what it looks like when you're given these Optison contrast bubbles. So it's a pretty cool technique. And right now there's a multi-center trial underway, so hopefully that will get reported. But the best possible result is if we can increase sensitivity and specificity of ultrasound. Maybe that will be another way beyond just a prediction rule to determine who does need a CT or who could safely avoid it. So it's also getting talked about a lot to look at other things that have to do with perfusion, compartment syndrome, appendicitis, in our world, necrotizing enterocolitis. It's being used for breast masses, liver masses, transplant graft perfusion, coronary arteries. So it's possible that this is the next technology that we're going to be seeing a lot of, not just for trauma, but for all types of things. And if you think about it, here we're blessed with CT scans everywhere, but in the rest of the world, ultrasound really may be the best modality, and certainly I think for trauma, ultrasound in Africa and the rest of the less advanced world and medicine is probably where this is going to go. So I think contrast enhanced ultrasound may be kind of the next step. It's still under investigation, but it's low risk. There's no radiation. It's cheap. So I think it's pretty promising. So bottom line, take advantage of labs and plain films, especially in hemodynamically stable kids. Don't use FAST to exclude injury, but I do recommend using the 5-variable rule and be selective. And I think they're going to have questions at the end.